you all for joining us today. This continues our monthly webinar series for the South Dakota Diabetes Educators Network, which was created as part of a previous work group with the South Dakota Diabetes Coalition to better connect diabetes educators from across the state of South Dakota. And so we did take an extended summer break for our webinar series, but we are back now and we'll be resuming our webinars monthly, the first Tuesday of the month at noon. And so our presenter for this month is Annette Johnson, who is a pharmacist at Avera McKinnon Hospital and University Health Center, and she will be presenting today on diabetic education in primary care clinics, specifically the model that Avera has adapted in some of their clinics to provide diabetes education in the primary care clinic. So I will go ahead and turn the presentation over to Annette, and I will mute everyone else here for the presentation until it comes time for question and answer. That way we don't have any background noise. So I will let you take over, Annette.
Okay, thanks, Ben. So like Ben said, I work through Avera McKinnon Hospital, but I'm primarily housed in 3 of the clinics here in Sioux Falls. So 3 of the McGreevy clinics, of which there's one of them that I primarily do the most diabetic education at, and mostly because that's where I started and that's where it had primarily been. But my plan is to eventually move it to the other clinics and expand out from there. So I'm going to talk today about diabetic education in primary care clinics through my experience. So in the beginning, where this all started, to my knowledge, at least, was with Sue Johansson. She had started doing diabetic education. I don't know the whole history of how that got going and where that all started, but I do know that she had started at one of the clinics here in town, and that she had a system set up where they had just consulted her for diabetic education, and she had gotten to the point where she wanted to scale back on her time and semi-retire. So they were looking for somebody to take over that place and to continue doing the diabetic education in those clinics, because it had been successful and it was another avenue for patients to get educated about diabetes and pre-diabetes outside of having to go to another class somewhere, as that doesn't always fit for everyone. So with that, the changes took place in that we'd had some meetings, and I had met with Sue for a few times to see how she had done this process. And ultimately then I took over for the clinic-based diabetic education in about mid-February of this year. And since then, the process that occurs is that primary care providers, as they're seeing patients, they'll identify patients who could benefit from diabetic education. That could be somebody who is pre-diabetic, somebody that is newly diabetic, somebody that is diabetic but just doesn't have very good blood glucose control. So they maybe need either a refresher in diabetic education, or they maybe never even actually had any diabetic education, even if they've had diabetes for a few years. So I get kind of a gamut of people to come in and meet with me, and I kind of tailor their education based on where they're at with their diabetes and their process. So once those providers do identify those patients, they then send a message to their nurse, either to their nurse or to their scheduler. Ultimately, it'll get to their scheduler, who then the scheduler will call the patient to set up an appointment. So I have set times during the week that I have openings for appointments. So I have 2 hours open on a Monday, 2 hours open on a Tuesday, and 2 hours open on a Thursday. So it's either Monday afternoon, Tuesday afternoon, or Thursday morning. I haven't had really any issues with patients not being able to be seen during those days, but I do leave it open to the schedulers that if there was a patient who if it did not fit during those days or times, that they could message me, and I would entertain, potentially seeing them at a different time depending on what my schedule was. I've also been able to work with that too in patients that sometimes they'll need to change an appointment after it's already been scheduled to maybe a time that's a little bit later, and that might not be what's open on the schedule, but knowing my own schedule, I can make that change. So once that appointment gets scheduled, they put it on an Outlook calendar that documents their appointments then, and so they have access to those, and I have access to make the changes on that appointment calendar. So the education that I provide is I go over the Living Well with Diabetes book on the computer. There's a few pages on there that I think are helpful to patients to see. Then I also go through the ADA Diabetes book, the Your Take Control Guide, and also a separate handout that I have on Diabetes Meal Planning Guide. And all those, except for obviously the computer one, the patient is able to take with them. Typically they are 1-hour appointments. And sometimes I do follow up with them on the phone. I, at this point, don't have a set schedule where I follow up with them physically in clinic. The appointments, the education that's done is no charge to the patient. I do not bill for them. That is the way that Sue had it set up before I came in. And so I didn't want to rock the boat with the providers or with the patients, and so I kept it that way. Similarly, and how the process is set up is how it was set up when Sue was there. We had agreed that, you know, in order for the providers to want to continue on with this, we just didn't want to make a whole bunch of different changes and then have them, you know, not be happy with, you know, the new person coming in. So we've stuck with the plan, and it seemed to be working so far. So after, you know, since I've been doing this since February, we found some outcomes. So I've had 52 patients at the Family Health Center that's out on Marion here in Sioux Falls. 9 of them at one of the other clinics that I go to on 69th and Western. 11 of those patients were pre-diabetes patients, so did education with them. The average A1C lowering of the patients that I have the results back on, or that have at least had a follow-up A1C, the average A1C lowering is right around 1.5%. And then digging a little bit deeper, I looked into it and saw that just shy of 80% of the patients reached their A1C goal on that next visit when they had come in to see their provider. That is all I really have about what's going on. I'm sure I've had some holes there and some questions there, so I'd certainly be open to entertain any questions that you might have about this process.
This is Deb. How do you handle it then if they want to, do they get referred to outpatient education then to go through like group classes if they're Medicare, or, and then do you document a note in the record about your visit and then put a no charge code, or?
Yep, so basically what I do is, since the appointments are just on an Outlook calendar, I'm able to go into our EMR and just put a chart note in. So I make a chart note with the diabetes educated detailed as to what I had talked about with the patient. And then I haven't gone as far as referring them to the group classes that we have here. More so, I just haven't quite figured out what my place is exactly with sending them there versus discussing with the providers further education. I do know that there are some of the ones that I do some initial education with that their provider has also scheduled them for the classes, but just wanted them to get like more immediate, like, you know, that day or within that week, just initial diabetes education too.
Okay, so you're not just trying to figure out, you know, when you've got we've got our education program here in the basement of the clinic, and so there's times we'll go up and see a patient upstairs, and at that time you have that window of opportunity. That might be it, you know, where you can sit down and work with the patient. And so I'm just trying to figure out the process then for the referrals into outpatient. So they wouldn't even go, and we use Epic, so you wouldn't even put them in as an Epic appointment. You would put them on an Outlook calendar, so they're not even registered, correct?
Yes, yep, that's the way it is, and that's the way it was set up before me. I know I see other patients at other clinics that I actually have them in as an appointment, and then it'll show up under that, but I don't bill on those either when it's just for a diabetic education, because I want to be consistent with the other clinic that I'm at.
Do you think it's affected your numbers in outpatient at all, or not really?
I'm not sure on that one. You mean from the standpoint of the class, the diabetes classes?
Yeah, or you know, sometimes sometimes that first visit can just be that they want you to work with them on insulin training and you're getting them set up, and then you can refer them to outpatient education for additional education.
Right.
You know, I mean,
right.
they blend well together. I
Yep.
kind of do that already, and I'm just trying to, my mind's just rolling here. I'm trying to figure out, just trying to work through the process here a little bit.
Right. So I think there's a mix of that. So I do have some ones where they want me to just train them on insulin and maybe do more of their insulin management. And so I will do some education there. I think a lot of the patients that are scheduled to do this may have issues where cost, they can't afford to go to the other, to go to a group clinic or to the group sessions. Timing, the group sessions are on set days, and that might not work within their schedule. And sometimes I think it might be daunting for some patients to go to a different place, that this is in their home clinic, and they know where to go, they know who to, that their provider is, within that space. And so I think there's a variety of different reasons there why they'll refer them to this setup.
So in your note, you call it diabetes education, or how do you title that?
I do.
Chart
Yep, I do.
Okay.
Mm-hmm.
Okay.
I do pre-diabetes education or diabetes education.
Yeah, pre-diabetes just doesn't get, that's what we're running into now. We get these, have been for a long time. There's no coverage for it.
Right.
And, just trying to figure out how to do that. Okay. I don't know if are there a bunch of other people on the call?
Sorry, I realized I was just on mute there and talking to myself, I believe. But there are some other individuals on the call here too, but don't let that prevent you from asking any further questions you might have. I also do have a brief piece to share as well from my end from the diabetes educator work group that concluded last spring. As part of that work group, they developed a slick sheet that summarizes having a certified diabetes educator in the primary care clinic. And so I was just planning to run through that as well on this work group. It's not a model that has been tried in South Dakota yet, but it's a model that the CDE work group studied from other communities and other states, specifically Utah and California, and then used that model to craft the slick sheet. So I'll continue to leave it open here for questions for Annette, and then we can jump into that overview of that other model as well. So any other questions for Annette and the work that she's doing offering diabetes education in the primary care clinic? No, it doesn't sound like it. So I will go ahead and jump over here to share a little bit the model that we have available from the South Dakota Diabetes Educators Network. And this model was developed as part of our CDE work group here. So is everyone able to see my screen with the slick sheet on it?
I see you.
Oh,
I just
that's
see your
not
picture.
very helpful. Oh, at least it's my picture. I'm like, oh my gosh, I'm sitting in the office. I wasn't prepared to be on camera here. So, oh, I just have to click share. That may help. Now does it show?
Yes.
Okay, perfect. So the Certified Diabetes Educators Work Group was a work group that met up until May of last year. And the purpose of the work group was just to identify, first of all, who was a certified diabetes educator in South Dakota, then identify who was doing diabetes education in the state and try and bridge the gap to assist them in becoming a certified diabetes educator, and then also to further promote the CDE profession across the state. And that work group certainly recognizes that there's many individuals in South Dakota providing diabetes education who are not certified diabetes educators. And so we didn't want to shy away from staying connected with those diabetes educators and certainly promoting CDEs, but also noting that some individuals are unable to obtain CDE certification just because of the hours required and some other necessary steps to become a certified diabetes educator. So right now, this slick sheet, I wanted to give a little intro here, is specifically regarding certified diabetes educators in a primary care setting. However, when we're looking at the term certified diabetes educator, we're looking a little bit more at someone providing diabetes education, if that makes sense. And we'll get to that a little bit further along here. So I won't read through it all because this will be something that I'll send out to attendees and post on the website as well. But this summarizes here what is a certified diabetes educator. And before we jump in a little bit more to the benefits, which I think are pretty self-explanatory, I just wanted to note here that the way that this is set up and the way that having a CDE in a primary care clinic is able to be done and include billing for the services to make it sustainable is that this certified diabetes educator or individual providing diabetes education would need to be a physician's assistant, nurse practitioner, or a doctor to be able to bill for the diabetes education provided. And there's all kinds of CPT codes that go along with it and G codes and all that good stuff. But really what it comes down to is that there are individuals, much like a provider, a provider in general could provide diabetes education. And so other states, organizations, et cetera, have adapted to have an individual within the primary care clinic who expresses interest in providing diabetes education, and that individual is who really provides all of the diabetes education and serves as the referral source to DSMES, or Diabetes Self-Management Education, at a formal program. And so it's a little bit confusing, but that's really the workarounds that these clinics are able to utilize to have someone in the primary care clinic. And these clinics that were studied in this work group were found in Salt Lake City, Utah, and the San Francisco, California area. So to become a CDE, you have to have so many hours of patient education throughout a certain amount of time. And for those two locations, both Salt Lake City and San Francisco, I think both of them have a population probably larger than the whole state of South Dakota. And so they were able to obtain all of the hours to receive certification to become a CDE. But that PA, nurse practitioner, or MD who's set up in the primary care clinic as being the kind of go-to diabetes educator doesn't necessarily have to be a CDE for billing or reimbursement, but this work group promoted it as such, as the work group was partially pulled together to increase the number of CDEs in South Dakota. So there's benefits broken down here. I won't read through them all because they're pretty self-explanatory for those who are doing diabetes education already, but there's benefits to the patient, specifically the timeline. Similar to what Annette had presented on earlier, she has a couple times throughout the week where she is able to meet with the patient, and those hours are set aside specifically for diabetes education. And so depending on the time that it might take to get into a group class at DSMES or schedules for the diabetes educator at the program, it really would depend there. And then it also provides a little bit of a transition, keeping the patient in their primary care clinic for that first visit with a diabetes educator. And then also the cost as it's billed differently as well. And then there's benefits to the clinic. There's a little bit of revenue to be able to sustain that position. It's an initial visit that's local, where the patient stays with the clinic, and then of course the improved patient outcomes. Those outcomes also carry over for the primary care provider as well. along with collaboration, increasing collaboration, and then improving quality measures due to referral to education. And then one of the kickbacks that the two sites that we studied as part of the Slick Sheet development, being Salt Lake City and San Francisco, one of the kickbacks that they had from their diabetes education programs right away was that they were taking away patients or providing them care only in the primary care clinic and not providing referrals. And so in that model, this diabetes educator also served as the referral link between the primary care clinic and a formal DSMES program. And so jumping onto page 2 here, we have a little bit of a workflow process, and I'll try and zoom out a bit so that you can see the full workflow process here. I guess I can't manage to zoom and talk at the same time here. There we go. So this workflow process is really set up so that everyone benefits from this process. There's the primary care visit where the patient visits with the primary care provider about diabetes diagnosis or change in care. Then they're referred to the clinic diabetes educator. They visit with the clinic diabetes educator and receive initial education. And then that clinic diabetes educator refers to a formal DSMES program. Then the patient attends the DSMES program, and then they continue to follow up with their primary care provider. So it provides a couple opportunities for the patient to receive diabetes education, both with that in-clinic diabetes educator as well as a referral to the formal program. And unfortunately, due to cost and billing and many other barriers, some patients don't always make it all the way to the DSMES program. So this kind of serves as a stopgap for those patients who might not receive any education to at least receive some initial education with that diabetes educator in the clinic, and then also to send along that referral as well. So that's really the workflow process that was studied by the Diabetes Educators Work Group this past spring, and now has been developed into this Slick Sheet, which just serves as a very basic overview of how that concept would work. If any organization was looking to explore that further, we certainly would encourage them to really take a deep dive into how this model is set up and how it works. And also knowing that this model works differently for any and every clinic. So for example, Annette is providing her services at the Avera medical clinics and not billing the patients. So that's certainly a bonus for those patients who aren't having to even pay a copay to receive her education and services. But for other clinics that might not be fortunate enough to offer those services at no cost to the patient and are looking to sustain that diabetes education within the primary care clinic, it is able to be billed as a visit for the patient. And so that really ties back into that reimbursement piece and making it so that the clinic could look into adding this type of position within their clinic.
Ben, what billing codes do the ones that bill, what billing codes are they using? Because that's then if the CDE is a nurse practitioner, a PA, or an MD, correct?
Yes, so their billing codes, they're billing as a PA, NP, or MD. The CDE like is totally, yes, yep, the CDE is totally separate. That's really from the way that the work group shaped this. We just included the CDE piece in here because that was one of the goals of the work group, was to increase the number of diabetes educators within South Dakota. Mm-hmm. But really, this could be, any provider within a clinic who wanted to take this on. Certainly, it would be up to the clinic, to the local diabetes education program, administration, et cetera, to identify what training they might want that individual to go through. So if they want, they'd want to have, if there was one specific provider within a primary care clinic who was going to set up this model and work to educate patients about their diabetes, they would want to make sure that individual had some sort of formalized training, whether it be going through the International Diabetes Center or going through ADA online trainings or something like that. That would certainly be up to the clinic to decide that. Any other?
We do, just like I said, I'm just kind of thinking through this a little bit. We go over to a couple of the clinics and do a diabetes clinic day with a provider, where as an educator, I'm there, nothing, I'm not billing them. I spend a few minutes with the patient ahead of time, go back out, work with the provider goes in, sees the patient, they're billing for their visit. And then if they decide they want to put them on insulin or something, then I go back and do the insulin instruction. And then I talk to them about, getting a referral into outpatient education, if that's what's appropriate, and then you look at their insurance and all that. So it's kind of the same thing. It's just a little bit different approach, but it'd be similar. I'm thinking we don't bill for that, so it'd be similar to what Annette's doing. And then we can help generate those referrals and just trying to identify who would benefit most from, whether it's M&T or DSM&T or even the IBT program. Okay. Anyway, I like how you got this laid out. So.
And I'll be sure to share the slides too on the Diabetes Coalition website from both Salt Lake City and San Francisco. They take a much deeper dive into this than this, front and back slick sheet does. But they really identified a lot of barriers early on and were able to break down a lot of those barriers. And the ultimate goal of this is obviously to provide more diabetes education to patients with diabetes. And so both programs found that they had an increase in the number of individuals who attended some form of diabetes education if they were receiving it right there in the clinic. But then they also saw a large increase in the number of patients who were attending DSMES at the recognized program level and attending a group class. And so there really were a lot of benefits to setting up a model where you're providing some sort of primary education within the clinic and really meeting those patients where they're at in the clinic and breaking down some of those barriers. So,
yep, absolutely. And Annette, are you still on?
Yes, I am.
Okay, so I think I took a note here. You made a comment that you don't schedule follow-up visits for them to come back. You do that initial, and then from there, it's kind of, if they need more, then they would get referred to the outpatient program.
Yep. Or I might do a phone call follow-up, or So it kind of is patient dependent on what they need. Yeah.
Well, and that's kind of your safeguard, so it's not replacing your program,
right,
so that it doesn't cross the line. So okay, got it.
Yep, definitely.
Awesome.
Great. Any other questions regarding the information presented today?
I think it looks great. Appreciate it.
All right, great. Well, thank you everyone for joining us, and I will get this posted on the Coalition's website with some supporting materials as well to further provide information about opportunities for having a diabetes educator in the primary care clinic.